So as I was saying, this is working jointly with Vincent, Kate, and Lorraine. And the title is Target Trial Emulation for Policy Evaluation. And it brings together work over the last few years, but also many presentations that I've given to different audiences. So you may have heard, if not everything, many bits of this if you have attended any of the Radiance courses or attended any conferences on causal inference. But I've tried to put it all together into a story that is useful to current and future users of eChild. So I will start really with what we do. What are the questions we usually ask when we work in public health research? We ask questions like, does the AstraZeneca COVID-19 vaccine increase the risk of blood clots? Or does additional health visiting improve babies' and mothers' outcomes? Or does, very topical, the ULEZ policy in London reduce respiratory disease in children? So these, as you well know, they're very important questions, and they are, most of all, causal questions. Ideally, we would like to answer these questions formally using randomized controlled trials, but randomized controlled trials very often are not feasible because they would, the question involves huge populations, and randomize people with such numbers will be too expensive or too impossible to govern. Or it also may not be timely, like with the questions about COVID vaccination. There was a need for a quick answer, so RCTs were not immediately feasible, or they cannot be ethical. It cannot be ethical to expose children to pollution at certain levels by design. And for all these reasons, we often recur to observational studies, such as eChild. eChild is an example of real-world data, whereby real-world data, I mean data that are not collected in sort of, they're collected outside of the world of RCTs. I'm very distracted by all these noises, so I'm really sorry. I'll try to ignore them. So we are talking about real-world data and how to use real-world data to answer causal questions. And eChild is a typical example of such data. But more generally, real-world data may include medical records, hospital admissions, disease registries, general practitioners' data on one side, on the health side. And in the case of eChild, we also have access to social science type of variables that come from school records, employment data, or social care databases. By putting together all this information, and we have access to a broad range of participants and very long-term follow-up, something that randomized controlled trials don't really have the power to do. And in addition to having such large catchment of time and people, using real-world data also allows us to investigate treatment received not under experimental conditions, say in a clinic, but under real-world conditions. So we can really say what a health policy may do, what impact it may have in real condition, in the real world, exactly. But as you know very well, such data sets are not created under experimental conditions and therefore are affected by several biases. The most sort of recognizable by all of you will be confounding bias. People may live in certain areas of London because of their wealth and therefore being less or more exposed to certain pollution exposure, or they may, at the beginning of the pandemic, may decide to receive a vaccination because of some understanding of the problem or dislike of the problem and dislike of the pharmaceutical industry. So there will be bias, and such as confounding. However, what the topic of this talk is that some of the biases that affect analysis of observational data are actually avoidable. They're avoidable if we use principles which allows us to control better what we do with these data. So the talk will be divided into these two examples of avoidable biases that have affected the analysis of real-world data. what we can do to avoid these biases, which will introduce us to the ideas of target trial emulation. And then we'll move on to think how do we apply the principles of what are called TTE, target trial emulation, when we want to evaluate health policy and not pharmaceutical intervention, which is where target trial emulation has been mostly applied. And then I will draw some conclusions. So I said I will talk about two examples of avoidable biases. The first one is a very well-known example of the analysis of postmenopausal hormone replacement therapy, HRT, and the risk of heart disease associated with it. In the mid-90s, it was believed that actually HRT acted as a protection against heart attacks. And this was supported by one observational study, the bottom of the slide here, which is in 2000, and then produced some estimates which were then revised in 2006. But in 2000, they reported using data from the Nurses Health Study, which is a famous cohort study based in Boston, which they compare women taking or not taking HRT, and showed a hazard ratio of 0.61, which was significant, indicating that HRT was protective against heart disease. Soon after, there was actually the results of a famous randomized control trial of HRT use in postmenopausal and actually also premenopausal women. But for postmenopausal women, the report of the trial was that actually HRT was harmful, increasing by 24% the hazards of heart disease. So what was the conclusions, the discussion about these two very opposite results? Initially, there were the attribution of the difference was there is unmeasured confounding. The participants to the nurses' health studies are highly selective, they're nurses, they're health conscious, and therefore the users maybe also have other health behaviors that protect them against heart disease, which are not accounted for by the variables that were included in their analysis. However, there is another explanation, and this comes from these observations of looking at the details of the two sets of studies. In RCTs, women were randomized to either initiate, or not start HRT. And the analysis, because of randomization, was simply a comparison of assignment to initiation versus no initiation. So the hazard ratio of 1.24 was a comparison of starting or not starting HRT. On the other hand, the observational study relied on data, self-reported questionnaires about their use, the nurses' use of HRT, where they classified whether there were current users, past users, never users. And this questionnaire was sent to them every 2 years. And with these data, the analysts of the nurses, the initial analysis of the nurses study was comparing just the current use versus never use. And so you can see there are two big differences here. In the first, obviously, the RCTs use randomization. Observational studies will be affected by confounding, maybe unmeasured confounding after certain variables are controlled for. But the other big difference between the two sets of results comes from asking different questions. The RCT was asking the question, should a woman start or not HRT? Because these were initiators. They had never used or not used for at least 2 years HRT before entering the trial. The observational studies had compared current users. So the current user was a heterogeneous group of new users, maybe over the last 2 years, or users that have been using HRT for 2, 4, 6 years. So there were a combination of sort of survivors of HRT treatment versus never users. And you know that HRT had side effects which may lead to someone discontinue their use. So the long-term users probably are very different from one that decides to start using HRT. So with these observations, a new analysis of the nurses studies was carried out by Hernan and published a set of papers on this. And when they redesigned, they used the observational data in a different way, where they only looked at women at a given point in time who had not used HRT in the previous 2 to 4 years, and they compared those who initiated at that point or did not initiate. they found that it has a ratio of 1.05, which is quite consistent with the results reported from the RCT. Of course, there could be still some unmeasured confounding because the first results is based on observational data, but the lesson to be learned is that when the same question is addressed, we get similar estimates, and therefore care should be taken towards the questions one should ask. And the example of the first set of opposite results probably was a combination of, yes, probably confounding bias, unmeasured confounding, but also, and above all, it looks an example of selection bias, where the study population, the data they were using in the observational studies, was not the same as the target population, that if they wanted to compare the results to an RCT. So care is needed in thinking, what is the question? Is the question related to starting a new treatment or being on treatment? And we're asking different questions initially. Second example, by the way, if there are very quick questions, I'm happy to answer the questions now and then leave time, but then leave time for longer, so more substantive questions. So do interrupt, shout, or send a text to a message in the chat. The second avoidable bias or the second example of an avoidable bias consists of thinking about when to start counting people, counting the follow-up of people. Because with observational data, with administrative data, we often don't have exact dates. Like in RCT, you're randomized, your follow-up starts at randomization, and the randomization you're assigned either to one group or the other. So eligibility, start of follow-up, and treatment assignment coincide. But with observational data, those times may not correspond. And it may happen that you think you start, you select your population from your large e-child database and say, these are, as you will see in the example later, these are all the children who attend school, primary school, and who are affected by a certain condition. That's my population. But then I want to know whether or not they're exposed to something. And that something, from the time in which I start following them up, may not be known at time t0. It may be recorded at a later time in the data structure. If this tx, that I call the time of which the recording of the exposure is taken, is very distant from the t0, we need to be very aware that we should not consider the children or the participants who are recorded to be exposed as exposed from time 0, because during this time, they are not exposed. So if the study entry is different from the start of exposure, we should not retrospectively assign the exposure at the time of start of follow-up. And this is a typical example of immortal time bias, because those who are exposed, say, 3 months after we start following them up, if we say that they were exposed from time 0, although they were not for the first 3 months, we sort of add a period of 3 months of survival into the study, because there could be other children who were lost to follow up or had the event of interest in between during the time in which they could have started the exposure, or started to be exposed, but we don't count them as exposed. So ignoring this interval of time between entry and start of exposure and treating it as if it was irrelevant may introduce such bias. So again, it's not a problem of the data, it's not a problem of the observational data, it's a consequence of our own manipulation of the data. So how can we avoid these biases? Well, good randomized controlled trials do not suffer from confounding bias by design, obviously. And well-designed randomized controlled trials do not suffer from selection and immortal time bias, because the study design is controlled well ahead of data collections. RCTs always start with a protocol that has to go through all the ethic committees and the approval from the funders, in which the population eligibility is defined, the follow-up is defined, how the exposure is measured is defined. And because all these features are defined before data collections, these errors that I've just described should not occur if they're well designed. Because the protocol clearly defines eligibility, exposure, assignment. I've already said this. So what should we do? We should ideally do exactly the same, with observational data and use the same design steps, whether the data are experimental or observational. And this is what was suggested in 2016 by Hernan and Robbins, when they proposed a formal approach of using the same design principle of randomized control trials in research based on observational data. And in fact, this paper, which is worth reading, is very beautifully explains all the component of emulating target trial, really relied or was inspired by the work that Hernan did with the nurses studies in thinking about what was the bias in there. So, I'm sure you've heard about this before, and I'm repeating this to you, maybe even personally. I may have told you before all this. But the truth is that target trial emulation has become very popular, especially in pharmacoepidemiology, when they use with pharma data, suffer potentially of these potential biases more than other studies. And there was a systematic review by Hansford worth reading, where they look at the number of papers published which used this approach. And if we had the results for 2023, it probably would be up here, because every journals I received the index from seems to have examples of target trial emulation. So let's think of, in practice, what does it consist of besides the principle of trying to use the same logic of a randomized control trial? Well, it gives us guiding principles for the design and the analysis. Both aspects are very important. I've tried to stress how important the design is, but I will stress next how also important the analysis of the studies should be guided in the same way as in RCTs. And as I said, it's well established in pharmacoepi. But because the observational nature of the data, we cannot think of emulating or using the principles of double-blind randomization, double-blind RCTs, because the real world is not blind, not to the user, not to the person who gave the treatment or the policy. So what we can think of emulating pragmatic trials, which are trials delivered in the general population where there is no blinding of anyone, and it's probably administered differently because there is some heterogeneity in the general practitioner or the school teachers or whatever. There is a sort of heterogeneity of that intervention, but still, you can still think of removing any systematic biases and still ask the question, what would happen if that policy was acted upon? So we are looking at pragmatic trial in that sense. And TTE consists of 3 iterative steps. And the first one is the most important one, is formulating the questions. We need to say what we're after before looking at the data. Are we asking, does the exposure E improve the general, does HRT increase or reduces heart disease? That's the question. But you have to say also in home, in people who never used it, of a certain age, during a certain period. So the question has to be quite specific. Then we design the ideal pragmatic trial, is the second step. And there are no limitation of money or time or feasibility or even ethical issue. You just imagine you could ideally design such a trial. And once you've designed such ideal trial, you try to translate those principles into what you can actually do with the data you have available from the administrative data. And you need to ask yourself, can I actually emulate that particular trial? Maybe you can't, because if you wanted to see whether HRT was given by, your question was so specific that the dosage of HRT was well specified, or the timing of the HRT was well specified, and your administrative data don't have that information, then you cannot ask that question. So if the answer is no, you change your question and you acknowledge that you would like to ask a very difficult questions, but you can't. And then you may say, well, but this is a secondary question, which maybe is also useful. And you go down until you say yes. You may also end up here saying, no, this question cannot be addressed, and you have to acknowledge that and maybe stop, as we will discuss at the very end. So I'll just spend a few minutes talking about step 2 and 3, because we assume that we have a question well formulated. So we'll have a protocol for the ideal target trial, and usually RCTs have got 7 components: who is eligible, how long we are going, when we are starting to recruit them, how long we follow them up, what is the outcome, what treatments or interventions we are comparing, how we quantify that comparison, and we call that causal contrasts or estimates if you are a statistician, but it's equivalent words. And then once you've defined what you're after, you design your plan. How am I going to estimate that contrast from the data I have? And this is for the ideal target trial. Then when you translate it to the administrative data and you say, how can I adapt it? There are some important difficulties here to think about. First of all, you want to think who is eligible. So can I, with my administrative data, identify exactly the same population? First question. Let's say you can. Recruitment period. Should I, because we have access to maybe 20, 30, 40 years of data in our database. Do we want to use the whole 40 years, or do we want to think of how things change over time in coding and quality? Maybe you restrict that recruitment period to a period which allows you to have a quite homogeneous data quality. Also, you want some follow-up, so the recruitment period has to stop before the end of your information, because you want to follow them up using the administrative data. Then you're thinking about outcome and treatment. Are the data measuring what you really want, or can only sort of have a very sort of loose definition of what the outcome and loose definition of the treatment? As I said, you may not be able to say HRT taken in the morning, or you may not have complete data on the dosage or in which women actually took the treatment. So you have to be sort of very considerate in thinking of all these things. And causal contrast, of course, has to reflect your question. In the analysis plan, when you're looking at the observational data, we'll have to take into account of confounding bias and think about the confounders that will allow you to interpret whatever contrast you estimate causally. And maybe if there is some form of selection bias because of missing data somewhere, you want to deal with the selection bias due to missing data as well, which is something that usually RCTs don't suffer from. So I've given you sort of the overview, and now I'm going to say, well, sorry, I forgot I have a little summary here just to zoom in or press on why we would want to do this. The first observation is that the causal question guides all our choices in these 7 steps. The second step that I really like, I think it's why I'm sort of completely taken over by this approach, is that the design is ahead of data handling. Because if you start looking at the data, you may get lost. You need to have a good idea what you're after. And if you think about the question and the design, you will minimize the chance that you introduce biases like immortal time bias, or the selection bias of including the wrong people, or including some of the wrong people. And obviously, the explicit causal contrast, I've already said, will guide the analysis strategy. Now, this is in general and applied very much in pharmacoepi. You'll see lots of examples where people describe all these steps and the translation from ideal trial to target trial, to actual emulated trial. But there have been recent application in health policy evaluation, which is where we come from. That's where each child is mostly of interest. And you've got some references here. And looking at those papers, you can see that the most important aspect is the challenges of exploiting the available data. So when you think about health policy, you're going into dimensions which usually are not very well defined from administrative data. And that will bring some consideration of whether you can or cannot really ask the question you want to ask. You may not be able to measure everything you want to measure. And the other thing that I sort of picked up from these papers is that there is, in this area, quite a lot of cross-fertilization with econometricians. And that's where Lorraine Deirdre really comes in. We have lots of discussions about our different ways of thinking and formulating questions and trying to answer them. So if you work with each child, do collaborate and talk with you. If you're a social scientist, with a biostatistician. If you're a biostatistician, talk with a social scientist. But I'm going to review some of the difficulties of these challenges, not all of them, as they refer to the 7 components of the protocol. And I will start with the eligibility, and then I think if we have time, I'll try to be, I realize I'm going a bit slowly, but I'll move on and go on. So first I want to say that the considerations are inspired by the work from the HOPE study, which is interested in examining the impact of special education needs provision in England. In England, more than 1 in 3 children receive extra education provision in school at different level, and a substantial fraction of these children are children with health needs, such as Down syndrome, or cleft lip palate abnormalities, or some other major abnormality. What I'm after is natal, so birth defects. But it's unclear how such provision improves their health and education, and this is at the background of HOPE. And what we want to know is whether said provision improves children's health and educational outcomes in the children who should receive it. And the exposure is SEND delivered at various levels, so there isn't just school support in the classroom, but it could be a more advanced support like EHCP, which is more than just SEND support. And we used each child. And note that because the higher level of SEND levels, so the higher level of SEND, EHCP, is funded by the local authority, and therefore there are geographical variation in the probability of receiving that support, depending on where you live, we are finding, or some variation. So each child, if you have attended the introduction day to the use of each child, you will know that it's a database constructed by linking data from the hospital episode statistics and the national pupil database. And this linkage captures most of the 95% of the births during the period in which each child, which are covered by each child, and that we have linkage to mothers' delivery records, so we have prenatal information and birth records informations. And there are other databases being linked, like social care. So it's a huge resource, and I leave to others to say more about that. Now the challenges, I said the first challenge is eligibility. In our study, our target population is made of children with a health phenotype, say Down syndrome, or cleft lip and palate abnormalities. And we want to, it's these such children with a typical standard, with a selected phenotype who experience primary education and therefore are potentially receiving SEN. And so let's say this cloud is our children who attended primary school during the period we're interested in. However, when we do this linkage of HES with the NPD, National Pupil Database, we may not identify all of our target population. Here, obviously, I made an exaggerated missed coverage, simply to be able to see that the clouds are separated. But the reason why they may not, each child may not identify all of our target population, it could be, first of all, if the children are not born in hospital, because the birth record would not appear in HES, in the health episode statistics, or the child may not appear in the NPD because NPD does not include private education, private schools, or there could be some simply linkage errors. And the linkage errors, as we know, may depend on the matching of names as well as date of birth, and therefore there may be more misclassification or misidentification depending on ethnic or social group. For example, those in private education would be generally higher social class, while those whose names may not be matching across the two databases may be from certain ethnic groups. So we may capture only this bit of our population. But so this is in general what each child does. But then within each child, we want to identify children with a particular health condition we're after. And that particular health condition may, again, be bigger than what we capture with each child. So what we capture is the joint area between each child and the health condition. So we will capture only this bit of the children with that condition. We'll miss out those not born in hospital, those in private education, and those whose names, for example, may affect the linkage. So that's the first thing to be considering when we look at administrative data just as this. Let me stress that this is an exaggerated version of how much missed coverage there is, but we need to be aware that the study population, the data we have, I mean, by study population, may not be the same as the target population, which is the whole of the blue clouds here. And being aware of this potential selection bias, which may come from different sources, social class, ethnicity, why they're not born in hospital, needs to be examined before we can extrapolate the results we obtain from the data we have to the population of interest. So we may say it's bias up or down relatively to what we want to capture. And we need to examine the probability of being linked, the probability of being hospital born, etc., to have an assessment, maybe via sensitivity analysis of how robust our results are. The second challenge is the exposure definition that we've encountered. So say, as I said, we're interested in SEN provision at the start of primary education. Just we want to know at sort of 1 point a definition of our exposure, not whether SEN was maintained over the years, but just let's ask a quick question, simple, that we want to know whether a child is given to SEN provision at the beginning of their school life, compulsory school life. And because SEN is recorded in a school census, in the January census, our T0 will be the January of year 1 of the child. This information, or which level of SEN, if any, is provided to the child, is derived from the school record. And therefore, we only include children who receive SEN if they attend state-funded schools. And therefore, we miss any child who maybe because of their additional needs, maybe has gone to private education because of their need. So we are losing them. But also, that's the challenge I want to put to you, is that SEN may have started before T0. Because some children, increasingly the majority now, but over the past few years, were not every child started school at reception, so the year before compulsory education, and may have been assessed to need SEN then. So the possible exposure may have started before our time of entry, T0, may have started a year before. But because not all children actually attend reception, we have this information only for the subset who started reception. So we have a problem of wanting to include our population is defined at T0, the eligibility is attending year 1 of school, but their exposure may have started before. So we have the same problem as with HRT in a way. Example that our exposure is not of new initiators of SEN, but of possibly continuing users of SEN. So they're prevalent users of SEN. And this may affect our interpretation of the results. And we need to be aware of this. How do we interpret the impact of an exposure, which is sort of diluted in time backwards? Now I'll go to the third and fourth question very briefly, and then I'll finish. The third question is, what questions do we ask when we are thinking about public health policies? Say that the outcome we're interested in is rate of unauthorized absences during primary school. This is something which is very topical. So what we want to know, we could have different questions to ask. We could ask, what are the benefits of SEN for children who actually received SEN? So would they have been more absent if they had not received SEN? Are we preventing some absences? Or we could ask, what about the other children who did not receive SEN? Would we have improved their attendance to school? Or finally, what would be the consequence of a new policy? Let's imagine a new policy that gives SEN to everyone, or for a subset of a certain group of the population. So there are different questions we may ask, and we need to be specific of how we are going to quantify the answer to those questions. And here I just list 3 possible causal contrasts that appear in the literature, in the causal inference literature. There may be, they do correspond to those questions, and you may want to choose one or the other, or ask all of them, but you need to be explicit in saying, this is the question I'm asking, this is the quantity I want to estimate. And to estimate that quantity, you need to inform your strategies of analysis, because obviously to obtain those different estimates, we need to make different assumptions and use potentially using different methods. 4th point, the analysis. If we want to draw causal conclusions, because they're public health intervention, we need data on comparable individuals. We need to compare apple with apples. Even if there are apples of different colors, we can control for the color or different subtype, but there have to be apples and apple. And you may well be aware that if your exposure is binary, what we usually do to assess whether our data allow us to compare individuals of exposed and unexposed as observed by obviously accounting for differential selection into the exposure, we estimate the propensity of being treated and draw and plot that propensity in those who receive the exposure and those who don't. So these are propensity score distributions of this group in our data is those who did not receive SEN, but they still have some propensity of receiving SEN, probably towards 0 here. But those who received SEN, they had some had a very low potential propensity, and but it was quite stable in the middle, and then it decreases. So there is an overlap in the probability of receiving SEN. This is, sorry, I should have said, this plot refers to SEN support, which is the first level of SEN provision, versus no SEN. So the children who actually receive SEN support, and in the population we are examining, which is the cleft lip and palate, and those who don't receive, have a sort of an overlap in probabilities of receiving it. So if we compare a child with that propensity of receiving SEN with a child with this, if we compare children with, say, with a 0.4, 40% probability of receiving SEN, we can compare the unexposed one with the exposed one, and say overall, in terms of propensity of receiving SEN, they can be compared. So we can compare a child from here to a child from here, and also a child from here and a child from here. Maybe not so much a child down here when there are those who did not receive SEN, there is hardly anyone who had a very high propensity. But in general, we say that this is a good example of what we call positivity. So there is, when the propensity distribution overlap, we say our populations, our observed data allow us, after controlling for confounding factors, which are summarized by the propensity score. I forgot to say that. That's what the propensity score summarizes, is the distribution of the confounding factors. Once we allow for that, we can compare these individuals. But sometimes, this is my very last point, that overlap, that positivity is not seen in the data. And these are the distribution of propensities in children who receive SEN support, which is the second group from a previous slide, the propensity of receiving EHCP, which is the highest level of SEN provision, versus those who did receive EHCP. So you can see there is very little overlap in the majority of the cases. And in this case, we need to recognize that such comparison of EHCP versus SEN support may not be suitable given our data in this population. And this brings me to the summary. I discussed 3 challenges, 3 main challenges that are specific to public health interventions. Eligibility, there is potential for selection bias, and the solution is to consult your data expert and interact with subject matter expert to understand what is the group that you actually can introduce, your study population, what makes up your study population. For the specification of the intervention, the causal contrast, clarify your questions before you start looking at the data. With the analysis plan, the potential for lack of positivity should be make us aware that certain questions cannot be answered. Also, final point, be aware that I have not even mentioned any of the other assumptions that are usually invoked to draw causal inferences from observational data, but that's a completely new talk altogether. So in summary, estimating the health effect of policy is practical, important, and an important endeavor. Combining the target trial framework with linked health and educational data enabled us to emulate policy relevant questions. I should say enables us to emulate some policy relevant questions. However, there are many additional challenges that need addressing. So for you, user of eChild, I will invite you to think carefully about your question and how you will define also your population of interest. And all this assessment of challenges should inform any results you find. Thank you, and sorry for